Good morning, everyone.
Good morning.
Happy Thursday. I'm just going to get started. Don't worry about if you have to grab any food or anything like that. That's totally fine. My name is Zachary Waugh. I am with Waugh Robotics. I am a physical therapist and business development manager for the company. So my job is to help build business around the product, an exoskeleton, and help clinics further incorporate it because that's where medical practices are starting to trend, including emerging technology like this. So I'm excited to share a little bit about you with the device, and I'm happily joined by one of our partners, Rachel, as well. So I'll let her introduce herself, and then we'll get things rolling.
I'm Rachel Busses. I'm from Oakland Orthopedic Appliances. We're based out of Bay City, but we do a lot of traveling, so we're down here today with you guys. I'm currently certified in prosthetics and orthotics resident. Got about 3 weeks left, and then I'll get certified in orthotics. And we've partnered, Oakland itself has partnered with Waugh, kind of being the tech experts, and their boots on the ground for being in clinics. So we're basically your on-call pit crew for the Waugh device.
I'll explain a little bit later why that's really unique in this area, but thank you all for your attention today. Feel free to ask questions towards the end if anything comes to mind. But before I roll through the actual presentation, I figured let's just show how the device works. So as you can see, I have a watch in my hand that operates the device. This would be what the actual user utilizes to get the device from sitting, standing, walking, back to sitting. So I'll hit a button right here. It'll get it to standing. And it provides the work. The user just has to help provide the tilt, pushing up as well. The device is standing. What you're not seeing is a pair of loft-strain crutches. That's something that we require all of our users to be trained in utilizing. So the benefits of having those crutches are that they've got 360 degrees of structural support should they lose their balance in a particular direction. So I'm just going to walk it forward, and I'll stop it right before I run into any of you guys. So the device works by shifting the weight from side to side, just like how you and I normally walk. So if I want it to stop, I just scuff the foot in the ground. So it doesn't have to look as violent as that. There are different thresholds that I can program into the device, so that way the device can stop more easily or or with more resistance, depending on if the patient has increased spasticity or anything like that. So I can rotate it around while walking. I'm just going to turn it just so that way I'm not bumping into any of you guys. But I can round around the corner too. So the right foot always initiates that first step. Always kind of feels like a march to the patients. Then I'll just stop right before I roll into that cable. It can go over it, but I'd rather not. So, if I want it to sit back down, I just would program it to do so on the watch again. It's about a 3-second delay. That cues the patient to put their crutches back behind them and get back into that seated position. So now it's sat. In the event that the device accidentally gets turned off, it's also got a graceful collapse function. So it literally goes down probably at this rate. So that way the user has time to either get a chair underneath them or get them safely to the floor. The user is trained with a companion, and a companion is required for use in home and in the community, which I'll explain a little bit later. So just wanted to give you a brief demonstration so that way you guys have a picture to the name as I roll through this presentation. So today I'm going to talk a little bit about the evidence behind our device, the Waugh, and kind of where exoskeleton technology is going and some of the challenges that we have in getting it out into the market. So as mentioned, I'll go over the Waugh itself, then I'll talk about the clinical and social impact of spinal cord injuries, some of the programs that we have and how we're overcoming those barriers that are limiting us in making progress, and the clinical evidence to support where we're going. So the Waugh was developed by Dr. Amit Ghaffar over in Israel. We partnered with him about 10 years ago and have since created the P6.0, which is the newest iteration of our device, which is FDA cleared for home and community use. One of the only ones of its kind. It is classified as a physical medicine prosthetic device, powered lower extremity exoskeleton class 2, if anyone really wants to know how it is classified. So over in the entire world, we've placed about 400 systems, approaching 500, I can tell you that. And we utilize certified training centers to do this. So a misconception is that we would go to a clinic and try to sell these outright to the clinic. And that's not the model for success with a device such as this, especially given how costly it can be. Instead, we're trying to train clinics to have therapists who can then help to evaluate and drive the process for the patients themselves. All of this has to start with a physician referral, though. So there is this collaborative team approach that's really important to nail down moving forward. I do want to mention the reimbursement support that we have here in Michigan. The strongest reimbursers we have in Michigan are going to be the VA, Michigan Auto, which is really big here in this state, unique to any other state, and Workman's Comp. The commercial payers I'll talk about a little bit later. We are working to bring them in, and we have had increasing success over the years in successful submissions and getting approval for reimbursement. So, as you saw, the ReWalk provides powered hip and knee motion to enable individuals with spinal cord injuries to stand upright, walk, turn, and climb and descend stairs. That said, little asterisk, it is not FDA cleared for stairs in the United States. We're working on that. That said, I have not seen any user who has their own device limited by that fact. So all devices are programmed to be able to go up and down stairs. We just don't extend that programming to anyone in the US because it's not cleared or regulated. And we want to make sure that we're playing nice in the sandbox. So the ReWalk, in my opinion, because I'm a PT first, I'm a champion behind it because of the fit, the clinical evidence that supports it, the walking speed that allows it to be a community ambulating device, how widely it is used, and the support that we provide from start to finish. So we understand that spinal cord injuries are not the most common neurologic condition out there, but they are costly, and they are costly year by year with individuals who have them. So I tend to even shy away from the phrase wheelchair confinement because I don't want to stigmatize the wheelchair community, nor is this device intended to replace the wheelchair. If you're looking to do a foot race, the wheelchair is going to win any day. If you're looking to stand up, have a conversation, engage in normal community ambulation and community functioning, this device is going to be able to help out in that regard. So when we think about what being in a seated position all day can do to you, though, the wheels start to turn and say, oh, maybe it is beneficial to pursue a device that can help them be upright because of the difficulty with bowel and urinary tract function in being seated all day. Osteoporosis because they're not weight bearing into their bones. Decreases in lean mass, gaining in fat mass, insulin resistance, diabetes, heart disease. These are things that can happen to those that are in a wheelchair if they are more sedentary because of it. So on the flip side of that then, we have these increased medical complications or risk thereof. We have increased healthcare costs. So the approach that I have with this ReWalk device is, in the long run, I really think this device is going to help, or any exoskeleton device is going to help just offset the costs in providing medical care to those with spinal cord injuries. So just a couple facts and figures for you all. There's about just over 250,000 people in the US living with a spinal cord injury. About 12,000 of them diagnosed each year. In the age of onset, half of them are between 16 and 30. Which is still a relatively young population of people, all of which would be great candidates for the device just by their age alone. So if we look at the cost, it's pretty expensive in that first year for all the medical care, the surgeries, the hospital care themselves. It's about $500,000. Then, $75,000 a year after that because of potential reoccurrence of different comorbidities or anything like that. The finances start to add up, roughly to $1.5 to $2.5 million in an individual's lifetime, which very rarely comes out of their own pockets. So, it can get into a very political conversation as far as who's paying for this, how are we all taking care of it. But really, the approach I want to take again is just saying, look, I want to think of this device as a cost-saving mechanism as well as something that can promote the improved quality of life for individuals. So even anecdotally, aside from the evidence posted here, anecdotally, every single patient I've talked to, I ask them, and I'm blunt about it, how is your bladder bowel program after using this device? And many will say, it's cut my time in half. You got to think in food that can take up to 3 days to pass in an individual who's been in a wheelchair or sitting all day, that could be a cause for a lot of problems. So that bladder bowel program, aside from the fact that it's an actual part of their life, it can impact the social aspect too. It's taking time out of their day to take care of these needs that are important to them. So giving them that option to be upright, allowing gravity to assist with certain things tends to help alleviate the stress and reduce the time. So this was a study that was posted that shows how long food passes in individuals with SCI versus non-affected individuals. Just from my understanding, how many of you are physical therapists here? Do we have any PTs here presently? How about physicians or? Great. What are the other medical practices that we have? Just so that way I know my audience. Do we have nurses? Do we have?
Chiropractic.
Chiropractic? Cool.
Neurosurgery.
Okay. Awesome. Physician assistant? Cool. We all know what it's like for a bone to not experience compressive forces on it. Osteoporosis can kick in. So it's funny, it's interesting to me, one of the FDA regulations for this device is that an individual has to have healthy bone mass. What individual with a spinal cord injury has healthy bone mass? It's not common because they're not ambulating normally to create that long axis compressional force to spark further bone growth. So through an SCI, that bone mass can continue to deteriorate over time, leaving them more brittle and more susceptible to injury should they ever fall. So my thought point is if we intervene early with a device, with an exoskeleton device, we can offset some of that bone mass loss and try to create more fortified individuals that can withstand everyday impact. This is a study reported in the Journal of Applied Physiology several years back that shows the difference in lean tissue loss between twins, one of which who had a spinal cord injury and the other one who did not. And even after a decade of out from the injury, there's an average of 7.8 kilograms of lost tissue mass from the individual in the spine with the spinal cord injury versus not. It's a pretty significant amount. It's nearly 20 pounds. So we want to try to offset that as much as we can by promoting being upright. So big picture outcomes. Restoring walking in people with paraplegia is physiologically, psychologically, and functionally desirable. Again, not to say that being in a wheelchair or using alternative forms of mobility is wrong. That's not the case. We're simply here to offer a different form of mobility. So in rehab, there are several devices that offer various simulations of being body weight supported, which are all great, and they all have a purpose. But they can't go home with anyone. The user can't take a Locomat home with them. A user can't take a body weight supported treadmill home with them. So do those gains really last? It seems to show that that's not the case. So locomotor training with partial body weight support over a treadmill has been shown to ameliorate some of the secondary medical consequences and show improvement in measurements of quality of life. Improve cardiovascular regulation, improve muscle activation, increasing metabolic demand, overall well-being. But those benefits go away when the individual doesn't go home with the device. So I'd like to, again, suggest utilizing exoskeleton technology as that means of transferring the gains that patients get therapeutically to a home setting. So I recently gave an in-service with an inpatient team, which is not normally a market that we try to, it's not normally a team that we try to market with per se, because not expecting the rehab sites to front overhead costs to pay for one of these devices. Typically, the patients are a little bit more medically unstable, so it would be hard for them to get in the device. It'd be hard for the clinics to house the devices. But we can start feeding the process earlier and saying, look, why don't we work on bed mobility? Why don't we work on wheelchair management? Why don't we work on pressure relief, which are all things that good inpatient therapists are going to be doing anyways. But why don't we do it with the goal of getting it into a device later on? And that's where good coordination between the primary medical team, the inpatient team, the outpatient team, and our team comes into play and saying, let's make this a goal to work for, which then tends to help build hope in patient populations as well, especially when they realize, I might not be walking. This device isn't meant to dangle a carrot and say, you're going to be walking normally. It's meant to say, here's an alternative form that you could potentially work up to and utilize at home and in the community if you're motivated and have the right support and means to do so. Just to review, there are different types of mobility devices. We have manual power assist standing wheelchairs. We have different kinds of passive orthotics, KFOs, RGOs, SCOs, and we have the powered exoskeletons. We're very open about the different competitors that we have, and they all have their pros and cons. So we have the Exo, which is used primarily in rehabilitation. We have the Rewalk itself, which is used for personal mobility, as well as the Indigo, and then the Rex as well, which originated out of New Zealand. KFOs can be utilized for walking. I have seen individuals use KFOs when walking at home and in the community. This is where I bring my PT hat in, though, from my clinically treating side. I left manual care, I left sports-based player care to do this because I believe in it so much. However, when I watch people walk with KFOs, it's hard not to cringe because it looks very taxing on their bodies, and I can just see down the line the orthopedic issues that are going to happen with their hips, their backs, their knees, and their ankles. So nothing wrong with having a KFO and knowing how to KFO walk. If anything, that's going to make you a great candidate for utilizing a powered exoskeleton. But it's hard not to see them and say, hey, look, maybe there are other options available that aren't going to be as taxing on your bodies. So KFO walking is there. It just creates certain gait deviations that the Rewalk helps to attend to. So I'll actually ask you guys, keep you guys a little engaged. What do you think are some of the struggles we are having as a company? And you can be honest. You can shout them out. Or put
Cost.
otherwise, cost is a big one.
Trying to get it implemented in hospitals or rehab facilities and things like that. Insurance coverage.
Absolutely. What are other things you'd be skeptical of? This is the time to be as critical as you guys want.
Technology failure.
Absolutely. There is a technical component. We used to shy away from, oh no, falls, we're going to brush that under. No, we're open about it. The device is a device. Machines can fail, things can happen. That's why there are safety components built into it. So, as I mentioned when I was upstanding and walking it, if the device were to turn off, or if the battery were to die, or if there was anything that would otherwise inhibit the device's normal functioning, it goes right into a graceful collapse. It's an isokinetic graceful collapse, so the more force on it, the slower it's going to go. It's kind of like trying to swing your hand in water. So that graceful collapse takes about 20 seconds, which is enough time to hopefully grab a chair, get them somewhere where you can lower an individual down if needed as a safety mechanism, so that way the device doesn't just accordion with the individual in it. So you guys nailed it. You guys made some very great points as far as some of the barriers that we have. Equipment, we talked about that, equipment failure. Reimbursement, as far as trying to finance this device. I'll say training is another one. Just finding clinics that have the time to get the 2 days in that we provide the training for is also really difficult. We offer at Rewalk, we offer clinics free training for any of their therapists, their techs, their athletic trainers, whomever they would deem appropriate to be trained and certified in the device, and then they're the ones who are helping to advance the evaluation, the submission, and the training for the individuals. I'm here for guidance. So even just setting up training can be difficult. The equipment itself, we're always trying to better how well the equipment fits to the individual and how well it simulates upright stance and walking. Market development itself, creating that buy-in, you know. Again, talking about people in wheelchairs or anything like that. The wheelchair it's going to far surpass the speed and the efficiency of this device, but that's not what it's being used for. So just educating the masses and saying, look, this is an accessory device that can be utilized to help facilitate upright standing, walking, and social engagement. It takes time to build that market around it. Reimbursement, this is a big one. I'm going to take just a couple minutes talking about this. So I'm grateful to be working here in Michigan because we have the luxury of utilizing, not luxury, but we have an additional resource in our no-fault auto, which is unique to Michigan and only Michigan, to my understanding. I do think there are other states trying to tap into it, but haven't quite gotten there yet. So Michigan Auto we've had complete success with submissions for MVAs. Workman's Comp, same thing, and through the VA. The VA, we're actually doing a national study at some of our large VA host sites that is it's basically a 90-day study for these individuals. 45 of those days are at the clinic, 45 of those days are at home. Then the patients would then get the device should they prove to be proficient in all the basic and advanced skills that we have them do. So the commercial payers, which I know everyone wants to ask about, we are working on that, and it is improving each year. So we have policy reviews that we are doing with the nation's top 40 commercial payers and saying, look, can you reevaluate how you're allocating your funds towards this device? Because let's face it, we're not asking you to buy 2,000 of these devices and burn out your budgets. This is something that one commercial insurance is going to get maybe 1 or 2 of claims a year on. So they're not going to be breaking bank compared to some of the other devices or medications that they're putting a ton of financing into.
How much are they? How much do they have to pay?
The devices?
Yeah.
They are listed at $118,500. Yep. We do offer rental programs as well. And then the VA, we've kind of negotiated a different contract with because it's not warranted. So the reason why it is $118,500 is because we've also included a 5-year warranty in it, which is unique to ReWalk among any other exoskeleton device. This device is going to get serviced every year by one of our certified service team members, and you get the entire benefits of the moment something happens, we're on it. You know, we don't have 5 million of these devices out in the market, so we know by name who has our device, where they are, and what's going on with them.
So as far as rehabilitation, I mean, does it have any kind of accelerometers or any kind of balance ability? I mean, as people are walking up and down stairs, I know it's not FDA approved yet in the United States, but walking up and down stairs, or I know you said that they have to use crutches at some point, but is there any kind of accelerometer or any kind of balance assisting device that's built into this?
It's a great question. So the accelerometers are built in to detect the lateral forces side to side to advance the limb. Okay. If I stand it up and hit the walk function, it won't go. It only goes when I shift it to the left. Okay. So I can actually demonstrate that really quick just to make my point.
You have to unload the one leg.
Exactly.
So you can walk.
Similar to walking. If I want to walk right now, I'm going to be scuffing my leg until I bring my weight over to one side.
So the person has to shift their weight.
You got it. So when we train individuals to walk, it's funny, when you first see a therapist, they look like they're dancing because they're doing this side by side. They almost look like they're skating. But we're trying to get that lateral shift, nose over opposite hip, to get this leg up. Okay. So this device is completely articulated in the sagittal plane. My therapist standpoint understands that walking is 3-dimensional. There's a frontal plane component, there's a transverse plane component, as well as sagittal plane. When I can meet Tony Stark, Iron Man, in person and learn how he makes his suits, then those devices will be more advanced and they'll just fuse to our skin. But in the meantime, this device primarily powers in that sagittal plane, but has degrees of freedom in the frontal plane to detect weight shifting and offload that leg. I do want to demonstrate it just to make that point.
Does it also, I mean, with the articulations in the knee and in the hip, does it allow the individual to initiate it with their own movement so that, you know, there's actual, they're rehabbing themselves? Like the more power they're able to generate, the less power the motors do?
Yep, okay. The device has the ability to be programmed to operate at lower and lower and lower thresholds So it allows that. So it's not powering the individual. It's saying, all right, you can give me some of that,
Okay.
and we're going to walk together with it. But there's no FES component to it. There's no actual muscle stimulation going on yet.
Is there a muscle, maybe not muscle stimulator, but is there muscle sensors to detect the contraction or the?
Unfortunately
electrical
not.
impulses?
It's completely mechanical.
Okay.
So there are mechanical sensors in the hips and knee that say, all right, are you contracting with me? Or are you contracting against me? Are you extending the knee when I need that knee to extend? Or are you flexing against that? Because if it's flexed too much against it, say during swing phase, if it picks up that flexion too much, it'll stop. It's built to stop at a certain threshold of resistance. Just kind of how I scuff the heel. Same thing.
So will it work with a high paraplegic, like a high thoracic level? Because like, what would then cause the patient to be able to move their legs if they're paraplegic?
That's a great question. So we do, and I'll show you kind of where we do have inclusion criteria, but it is clinically determined. So we are at a T4. T4 is our cutoff, but I have had people at higher levels of incomplete injury evaluated and successfly using the device.
Like C6, 7?
Yep. My biggest go-tos are: do they have good grip strength? Do they have good upper body range of motion?
Mm-hmm.
Do they have good trunk control? So really quick, if there's any gray space as to how this whole process works, basically it starts at the top with a physician referral to a ReWalk certified clinic, basically saying evaluate and treat exoskeleton training or ReWalk training, whichever you'd prefer. Users have the right to pick the devices that they want, but if a clinic is only ReWalk trained, we do want to kind of try to push that and say, look, we've got you trained in ReWalk. Let's just see how the patient likes it. They typically will then move forward pretty easily. So once they get that referral, the evaluation happens. It comes down to the therapist's judgment first. Again, I'm a PT too, but my job is to not step on anyone's toes. So if you've worked with someone for 20 years and you're like, I know this guy, he's not going to do that great. Oh, but he looks so good in the device. I'm telling you he's not. Okay, then that's the case. So it comes down to that clinical judgment. Once we then have that evaluation and everyone's all systems go, then right away we get that paperwork in and say, all right, let's submit on this patient's behalf, if that's the route we want to go, if we want to try to get reimbursement on this. Get all the patient, we get paperwork, we get the videos, we get everything. Our team will help with that. Then we put in that submission and we expect a denial. That's just the name of the game. We expect a denial because it's investigational, because it's experimental, because it's not medically necessary. We have all the documentation and paperwork to state otherwise. We submit that then through the appeal process and push for either an overturn on that or an external medical review. And we usually win those external medical reviews.
Yeah.
So how long does the battery last, and how long does it take to charge?
Great question. So we encourage people to charge it each night. It has to be turned off to charge. The battery will last 8 hours. Continuous walking, 3.5, 4 hours. So we have...
This 5-year warranty is on the battery as well?
Yes.
You don't paranoid about batteries.
Yep. Yep. They're lithium-ion batteries, and we just got approval to ship the batteries still in the device, which is nice. We had to used to ship the batteries separately. It was this whole ordeal.
Airplanes don't like
So yes, the batteries are warranted. The entirety of the device is warranted under that 5 years. So 3.5, 4 hours of continuous walking, 8 hour charge in a day.
Thank you.
Yeah, go ahead and take one of my cards if you want, right over there.
If once you're done, if you can right over here,
Absolutely.
I can finalize.
Yeah, absolutely. So there's no other device to the market that has walked a marathon. ReWalk has. And that's not me saying that from a salesmanship point. I'm saying that from a PT point of view. This device can walk those marathons. This device can be outside and withstand the demands of being on unstable ground. Other devices have cracked. Motors have burned out. To me, PT Zach is saying, I don't like that because it's not safe. Not because I don't think it's sexy for the device or anything like that. It's because I just don't think it's safe for a patient to have motors that could be burning out. So the device is heavy, but it needs to be, because if you don't have that support from here down, something has to make up for that weight.
Also, the patient doesn't feel like they're carrying around 60 pounds.
They don't. I've been in it.
Because they're supported by the device. So if anything else, they're feeling stable and stabilized in the device. So they do get their body weight through the bones, so we're increasing that bone density. But they're not adding an extra 60 pounds. That's where, you would be like, oh, someone who has questionable bone density, do we want to put 60 pounds on them? No, absolutely not. But they're not putting 60 pounds up because obviously we can stand it up and it is self-supporting device.
So this is a great point, actually. I know we touched on it a little bit earlier, but being here in Michigan is really, really cool because we've taken on Oakland as a distributor partner of ours to hopefully set a precedent for how we partner with other people moving on. Because of the people that they see, their feet on the ground looking at people that we might not have even caught. So at this point, just very quickly, Rachel, you want to kind of just reiterate some of what your role is with Rewalk?
Yeah, so with Rewalk, we're partnering with them to kind of be the pit crew. So we have a couple devices up in Bay City that we're working with. So our Bay City office is FDA certified in the Rewalk, so everything would be coming out of there. We have 2 orthotists and 1 prosthetist who actually live fairly close to Flint, Mount Morris, Grand Blanc area. And we're opening up an office down here too. We do have an orthotist who comes here and works with your physical therapist, Dan Oslin, if you guys have heard his name passed around. And we're working towards doing more of these types of things. So really what it would look like for the patient if we came in is they're working with their physical therapist and they're like, hey, we're not really sure if this is operating quite correctly. Can we give them a little more dorsiflexion because they have that capability? Or let's limit some of that dorsi assist because we want them to work a little bit harder when they're in the device, a little more stability and things like that. We come in with our Loctite and our wrenches and all that stuff, and we're really your pit crew coming in and working with the device. We want your therapist to be able to work on training the patient, training the companion, getting them in the device. If weight loss is a goal, that's a great thing for the therapist. But we're really the experts on turning the wrenches, making sure the device is set up correctly so that the patient gets the most benefit. And also, like Zach says, Rewalk does have a bunch of that stuff, but we're right in your neighborhood. So this is really the pilot program with Rewalk and an orthotic and prosthetic device company where we can get integrated right in with your physical therapist so that we're your on-call tech crew. Hey, I need somebody here tomorrow to, work on this Rewalk because we got the patient coming in that's not quite right. The other thing is we do own this device. So if we do have patients who are doing trials, we could do 2 or 3 trials in a day. The device can be set up for a whole range of individuals in height. So really we would measure the patient, we would get their patient profile, all that stuff. We would come in, set up the device, the therapist would get them in the device and start walking up. Once they're done, the therapists do their rerounding, we reset it up for the next patient, you get the next patient in. So not that we're turning around quickly, but we want to make sure that the patient gets the most time in the device to get the most exposure and idea of what is this really going to do for me. So that's kind of where Oakland is integrating with Rewalk, and then hopefully your trained therapists on how to get patients in the device.
Awesome. Thanks, Rachel.
Can the Rewalk be in the rain? Like if they're walking outside and it starts raining?
It is water resistant, not waterproof. So yes, it has been tested for 40 minutes in a shower and it has still been able to function, but don't go into the water with it.
So we would encourage, if it starts raining, try to get inside.
Right.
But it's not like it's going to all of a sudden shut off, system shut down, go down. You're not going to be stuck outside in the middle of anything. So slight rain,
right.
just get inside.
So seeing the device, seeing how it works, hearing what we've had to say, before I give you the answers, what do you think, and this isn't meant to be a trick question, what do you think an individual needs to be successful in one of these devices?
Self-motivation.
That's a big one. Absolutely.
Proper training.
Sure. Physically, we talked about upper extremity range of motion, talked about grip strength, talked about trunk control. Those are all necessary components. So these are our documented necessary inclusion criteria for evaluation and training in the device. So they obviously need to be affected by some form of spinal cord injury. They need the body strength, the range of motion to use the crutches themselves, especially getting the crutches back behind them. A good degree of extension and internal rotation has to occur back here because they're going to be pushing up from a seated position to come to standing, and then their arms out in front of them. They need to be able to tolerate standing to some degree. We can't have them going, we can't have their blood pressure dropping to the point where they feel like they're going to pass out every time they come upright. they would have to be on some other program first to improve that, then come into this device. The device ranges from 5'3" to 6'2", but really it comes down to the length of the femurs and the tibias. So most people fit that range, but if you've got someone who's taller, but their femurs and tibial lengths still fit the range of this device, then that's appropriate. Healthy bone density, which is determined by clinical judgment and physician approval. As I mentioned, this is the decision that's made between the patient and the clinician themselves with our guidance, and we help screen through that process. So don't worry about not being able to see what this all says. These are the two sets of inventories that we have that the therapists need to be trained on and the patients themselves. Basically saying this is what's going to allow them to get their own device for home. So when we do a training session for a clinic, we run through the entire basic skills inventory with them didactically, and then in real life with two patients coming in, that can hopefully turn into evaluations right then there on the spot. Since they're already got the script for this to come in, and with us being there.
I have to go.
No worries.
Because I have people.
What time do you got?
But it's 9:15 or 9:20.
Okay,
But
I'll wrap it up.
Thank you very much for the talk.
Absolutely.
And definitely, we have a couple of people that we'd definitely be interested in talking to.
Yeah.
Dr. Shaw was the one who was
I'll go
here.
talk to him
We'll talk
afterwards.
to him because we have one person in particular
Sure.
who'd like to get into this.
Thank you so much. So, I already talked about this a little bit earlier, but our ReWalk team helps in providing the reimbursement support from start to finish. How are the patients going to pay for this? So that's why, again, I chose to leave clinical care because I truly believe in this company because of how much help they provide from start to finish. Getting the prescriptions, getting the letters of medical necessity overall. In addition, we also offer partner portal marketing programs. So when we partner with the clinic, we then disseminate all of our marketing material to them so that they can distribute it as they would like to. So this is the clinical evidence itself. We understand that walking helps to reduce the risk of heart disease, diabetes, stroke, improves body composition, prevents bone density loss, and many other functions as well. Walking for mobility impaired individuals, the benefits are still there, especially if they're predominantly sedentary in the rest of their day. I mean, it's gonna help improve flexibility, strength, circulation. We've found reduced incidence of severity in pressure ulcers, both through pressure relief and improved circulation. In a study of the benefits of standing upright for SCI individuals, 33% of the participants reported a decrease in pressure ulcers when the assistive device was used more than once per day, which is a pretty big deal, I would say. Quality of life, even just anecdotally, it's great that the research is there and that there are emerging case reports coming out that show quality of life improves. But when you talk to these individuals and you just hear about their experience, it's a positive thing. I haven't had someone say, "This has made my life worse." I just haven't. We know that Berg, the overall Berg balance scale, their dynamic gait index, their heart rates, their blood pressures, all of these components are going to improve by utilizing this device, just as it would improve by doing body weight supported training in any sort of inpatient setting. We have a meta-analysis that actually helps to support this evidence, and it shows that powered exoskeletons allow patients with SCI to safely ambulate in real-world settings at a physical activity intensity conducive to prolonged use and known to yield health benefits. So this point where it's saying 76% of patients were able to ambulate with no physical assistance is basically saying they don't have someone guarding the back of them, because we do the companion training, but at home, we don't want the user to need the companion with their hands on. They just need to be present in the event of an emergency. The improvements go on. Spasticity, bowel movement regularity. What I really like is knowing that this device actually creates a metabolic demand similar to what you and I experience when walking. Not much more, not much less. So the users aren't huffing and puffing, not able to engage with the people that they're walking alongside once they're proficient in it. On the same side, we're going to see that it's still promoting the benefits of being upright without the device doing too much of the work. So I like to call this a worthwhile investment because I really do think that's the case. I told you outright, this device is $118,000. But get the device in the right hands, we could prevent several $100,000 in medical bills due to relapse comorbidities that might be coming back. So it's just something to consider when looking ahead. And I always joke with people, if Google came to us and said, we want to buy your device, we're going to make it 10 times better, by all means, go for it. But it still needs to get paid for. And that's what we're here to help pave that way with. It's saying, someone still has to pay for this. We're trying to set the policies behind that. If you want to go and make the technology better, good, great, go do it. But we still need to integrate this into the medical community to help overall offset medical costs. This study basically is just showing the increased demands in VO2 and heart rate that come with various activities and how they are matched and can be matched, again, by using the rewalk to assist with that. I really like this study, this one coming up. This talks about vertical ground reaction forces with walking. So at faster walking speeds, we actually start to simulate compressive forces on the bones that you and I experience on any given day when we're walking. So now we're starting to put Wolff's Law back into action and help recalcify these bones that might have experienced bone loss. So as we approach more community ambulating speed, we could actually be, in theory, promoting regeneration of bone density, which to me speaks volumes.
And what is the ambulating speed? I mean, is it as slow as it was when you were
That could be
demonstrating?
adjusted.
Okay.
So the highest speed that this device has been recorded at is 0.7 meters per second, which really has no bearing on what we understand things. It's a little over a mile and a half per hour.
Okay.
That said, limited community ambulation cuts off at 0.4 meters per second. That's enough time to get across the street safely at the turn of a light. Our device can consistently do that and has had those upper measurements to 0.7. So as educated healthcare providers, I encourage you to do your own research and saying, what speeds are these other devices going at? Because if they're not consistently going over 0.4, are they safe for use in community? Let alone, what sort of supporting devices are they using? Are they using walkers or crutches or anything like that? So that's why our device is heavier, because it has stronger motors that can produce faster speeds. So this is just a picture really quick of just showing some of the people that utilize our device. She just did her, I think, second or third marathon out in Manchester. So she's, over the several days, she would walk about 4 miles a day. Obviously, they'd have to recharge the battery each night. But the device withstood it. There were no technical complications that limited her from finishing her race, which I thought was really, really neat. Really do appreciate your time.